Hello.
Can you see my screen?
Yes.
Is my screen visible, Tanya?
Yes. Yes.
Yes. Okay, okay. So myself, Shobna and Dr. Jose, we were discussing about the scientific risk factors, and of which we were already talking about it, but now we are using this terminology because this terminology is something which is accepted by the universal research community. Pyroptosis, inflammation-induced programmed cell death. We all know apoptosis. It is simply programmed cell death for every cell in the body. So pyroptosis is inflammation-induced programmed cell death, which starts by enlargement of the cell and holes formation in the cell wall or capsule, and then cell rupture, and then it allows neutrophils through the endothelium. So pyroptosis is a process which is inflammation induced programmed cell death, which can be picked up only by our method, because all other methods are macroscopic. We only provide the cell surface cell line for diagnostics, and we can pinpoint whether pyroptosis has set in or not. So we have this advantage, and
But one minute, Dr. Pari, before we go into this. So
yeah.
let me just set the context. What are we discussing all of this science in context of? This is a parameter that is to be used in the development of the risk score diagnostic test. This is one of the things you're going to be measuring.
Yes.
So
Can
let
I add here, Tanya? In the last, we had a discussion before. By the good morning, sorry, and good evening to you.
Good
Yeah.
morning.
There was a discussion where we were trying to understand what is the unique value proposition that this technique brings, if it is to be used as a test, right? And if it is used in addition with other things, the claim is that it is a better answer. But if it is about one of the things it can do is that it can be an early indicator. Okay, so there are two different aspects of it. Now the question is, what is the evidence for any of this? The first one being the early indicator part, because that's where actually there's apparently no other indicator. Okay, or at least that's what, of course, it might be difficult to prove, but that's what I had asked them. I asked them, show me the evidence that we can gather from the literature for either of these two claims. So the first is that, it's an early indicator, which there may not be equivalent available for any other method which does the similar kind of stuff. And the other second part is that it is an additional parameter in a slew of parameters which improves the decision. Okay. Yeah. Sorry.
But
Yeah, please
Prem, I think so. Maybe we should sync up. I see always there's kind of like an internal meeting, because here's was so they were supposed to put everything in the context of the test, right? Of the development of the test, and the exercise was really to list all the risks that the development of the test would be. So maybe we can just convert all the work you've done into this, because it's one thing to say that nobody else is doing it, and a completely other thing to say, and this is why I said the most important discussion is first we need to even identify, before you go into any of this, we need to identify what is the patient population that you're going after, because, whatever method you're using to estimate, it's one thing to say it's an early indicator, but the completely more important thing is to say, how is this associated with, there is no, if you're not the only ones, there is no data set that will show that, right? So we can't look at this in isolation. We have to look at it in terms of the patient profile that you're going to be targeting the test for?
Yes.
Yeah,
So
I
this
think
is part of the this was part of the exercise of listing risks, in the sense if there's a claim, there is an uncertainty about it. This was the different. This was
yeah,
one of the
we'll cover
uncertainties.
that point, Tanya. Little later, we'll cover that point also. First of all,
Okay.
I'd like to emphasize the scientific component of it, the scientific parameters, which we are strong about, which, yeah. We would like to, highlight the scientific points where
So,
we are strong.
just 1 minute, Dr. Parikumar. So her point was that if there is a, let's understand who the patient population is, right? So for the early indicators, it's more about people who are at high risk and who are concerned and who want to look for some of these parameters. For if it is a measure of, the in that case, it's more of a health, sort of cardiac health quality indicator in that sense. But the
Yeah.
second part would be that it is sort of a diagnostic in that sense. But so we were just trying to understand, one of the risks is what is the clinical evidence for either of those, because if there's a good paper which indicates that there is a correlation, because people could have done studies even without necessarily using the conjunctival capillaries, right? So that
In our search, we could not come across any of such documents. We did a thorough search, and because it is not done by anybody else, what the pathologists have, the data that they have is from the pathological samples and physiological samples from animal models. So physiological human sampling is not done. So that is well documented. Well, I mean, it's established.
Yeah, so Tanya, are we going in the wrong direction? You can advise. I mean, I thought this was for the risking part. I mean, for the listing the risks and finding evidence to see if any of those risks can be reduced or retired.
So maybe I think I'm a little bit honestly struggling with this. Is you can't build a risk strategy on a tool without defining your population. So in last call, I think between Dr. Pari and Dr. I don't
Yeah.
remember his name, Jose, right? There was also the thing, should we go for neurology or cardiology? And what I told them, first define your population.
Yes, population is
Then
here now. Can you see my screen? Population is here. So
what is
less than
the
50 years.
population?
Yeah, less than 50 years, we would like to categorize them into symptomatic patients and asymptomatic patients.
But
Symptomatic,
symptomatic or symptomatic what? Who are these patients? Are they cardiac patients? How? What is the pool? Tell me physiologically what they are. Why
yeah,
would they even come in for this test?
yeah. Symptomatic means those who have risk factors, those who have diabetes, hypertension, family history
We've
of
gone back to the same, but we've gone back to the same thing. How are you making your life lighter if you pick up multiple factors, comorbidities? Do you know the company BrainC? I would highly advise you to do a case study. So look at BrainC. It's the first FDA-approved diagnostics to test that came up with the risk scoring. They did it for Alzheimer's. And I'm also going to actually send you all an FDA paper on what they're looking for. And please don't think of it as US regulation. Think of it more as what is needed for the diagnostic tool. So if you're now telling me these patients are symptomatic, they could have diabetes, they could have other things, I thought we had discussed that as soon as that starts becoming your proof of concept study, you already start to have a problem, because all these other risk factors will start contributing to your analysis. So wasn't the thought process that we would design a very pure proof of concept study where you will be able to prove your value propositions?
Tanya, can I just join in now? I was listening to the whole thing. we initially thought we will set an upper limit because beyond the age of 50, most people are likely to have a certain kind of
Disease
endothelial
phase.
dysfunction and a lot of comorbidities setting in. So we fixed the upper age limit to 50. Then we said the three use cases that we are going to study is cardiovascular disease, cerebrovascular disease, and
Dementia.
and dementia. Okay, so these three things: cardiovascular, cerebrovascular, and dementia. So in these three cohorts, we thought we will look at patients who are absolutely asymptomatic, nothing, they have no symptoms of any of these things. Then we come to the next cohort with them mildly symptomatic. They have some kind of symptoms related to a cardiovascular disease or risk factors related to cardiovascular disease or cerebrovascular disease and dementia. And then we have the third cohort who are patients diagnosed with these three diseases. So we thought we can look at these three cohorts and study their endothelial function. Also, another thought that went
Uh,
into this
I
to
think
look at
that is what, yeah, please understand. That's what I think Tanya is saying. It's a very complex system. Let me give you a contrasting system. Okay. And then you tell me what you think. So let's say there are perfectly, normal patients, healthy patients, right? But they have a family history of cardiac health issues.
okay.
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 So they have no other complications, just that, there's a long history of, everybody having cardiac health issues,
Yeah.
right? Now, that is another example where all those other complications are removed, right? So I think, if I'm not mistaken, that's what probably Tanya is pointing to. Can you design a cleaner study where all the complications are not there? It's just a very simple proof of concept, right? Now, this may not be the right one, what I told you just now, but I'm just wondering if you can think of something in those lines. Tanya, you want to comment?
No, I think, yeah, that was the proof. I thought that was the kind of journey, and this is not to undermine all the work that is done. This is just to say that you're fundraising, right? Let's just put priorities on the table. You're fundraising. What is your biggest challenge when you're suggesting that a new mechanism of action is there? You need to first prove that because you pick this metric, right? This is something that the whole world should be looking at. Your first study is to prove that. And this is why the heterogeneity of the population cannot be a complicated. You will have a very difficult time when the clinical readout happens. It's not about thinking of what you have to design today. It's to think of when the results come out in this population, can I really look at it and say that it is endothelial cell dysfunction in these patients that was responsible for it? And if you cannot establish cause and effect, it'll be very difficult.
Yes, I get you, Tanya, but this was just to correlate. But otherwise also, if we take only symptomatic patients with no comorbidities or even family history, if we take a pure set of patients, but then these set of patients we need to keep following them up at regular intervals. Then we will be able to say, okay, they had no endothelial dysfunction and they had no comorbidities.
Exactly. Now that makes sense because remember when I said you're not going to need longitudinal studies?
Yes.
What you said is exactly correct because now you're establishing a trend. You're saying at this point, the endothelial cell function is this much. Now I'm following this patient after 3. That would make sense. That is when the data comes out, you will have established feasibility.
Yeah. That means this cohort that I select should be devoid of any kind of family history or comorbidities, right?
It has to, exactly. It has to be like I gave you this example from oncology, right? When you test a drug in oncology, you do not test it in terminal patients, even though the whole world knows the only people who need it are that's because it's too complex a system. You cannot establish
Yeah.
cause and effect, right? So you always go through the very early ones. Yes, you need to think, and that would make sense to me. If you're doing longitudinal, you have a
Yeah.
base established, right? Then it's deterioration. Then your readout will mean something. Otherwise, you would have done this study and the data is not going to suggest anything.
But the whole point is, Tanya, we
Mhm.
fixed the upper age limit to be 50. We were thinking we can include some symptomatic patients or some patients with history alone, with family history. For example, he might be otherwise absolutely normal now, and like Premnath just pointed out, we can probably have one cohort running simultaneously as a longitudinal study also. A patient with no symptoms at the moment, absolutely healthy and fine, but has a family history of a cerebrovascular or cardiovascular disease or dementia. So that is why I was looking at that control also. Uh, that
That's
group of
different.
patients.
That's totally okay. Having a control, everybody will need to have a control, right? Because
Yeah.
what you compare it, and I was strongly reacting more to the heterogeneity of your cohorts. That's what you need to be
Okay.
careful. Of course, you should have a control population, and
Yes.
that would include all of this, right?
Yeah. So we've got somewhere. We are leaving out the patients who are already suffering from those diseases, just like how you said. And we will only do a longitudinal study on totally asymptomatic patients and a similar cohort with some kind of a family history. Right now, not suffering from any disease. So if we
Yeah.
run these two cohorts parallelly and at specific time intervals, we are able to repeat the tests and see how their disease progression happens, then I think we will have a real data set that can be extrapolated to the general population.
Yeah. I think just as a comment, see, that's fine. All this will work out if the length of the study is not too long, right? What we need to keep looking for is uh, more such cases where we can get a result in a reasonable period of time also, right?
Prem,
Because
but
Yeah,
I
yeah,
think last time somebody told them that and they went down the whole ED route after that, which is like a completely different value proposition. I think, look, if you're going to be a biomarker company that is adding value by changing the way we look at science and patients, it is completely okay to do a longer study, right? I think what
yeah,
investors react to is at the end of the study, they don't want that then everybody's sitting here confused. Oh, is it because of this or is it not because of this? Is it endothelial function or is it right? And every biomarker company goes through this. I mean, I told them it takes like 12 to 15 years to build a company like this. This is not a short story. You're in it for the long run. So if you're going to put the energy into it, then do it the right way. And that kind of the way would, to uh
yeah. But Tanya, there may be a few more such things that we can. So that's one set of population. So, for example, we may be able to even narrow it down to a set of patients who are at early stages of, where you can already see the problems and therefore you can track them over a shorter period of time, right? Rather than
sure.
completely healthy.
Yeah, so one way, just with the example that you gave, and Prem, hold that thought for me, please. I just want to respond to Shobha's. I don't want to give you all the idea that you'll have to go look for a pure patient population, because that's never going to happen. There will always be complications, right? But at least don't complicate it with metabolic diseases, diabetes, and all of this. That is a very, very tough population when it comes to reader. So just be mindful of that. To the question that you're raising. Okay, so it's always really about the design of the study, right? That's why I advise that you all look at BRAIN-C. So what BRAIN-C did, it's a risk score. So why I tell you all to study it carefully, it's a risk score that actually predicts which patients are going to progress from early MCI, cognitive impairment, to dementia, right? So if the path is like 5 years, they show that our risk score we'll be able to tell you which patients are. Look at the way those studies are designed. They're designed very carefully. So Prem, to the point that you're saying, if you picked heart failure, I don't know that you can do it. Okay, please. This is a generic example, which given your backgrounds, you'll are best suited to this thing. If you look at heart failure patients, right? Any test that can predict the progression of phase 1 to phase 2, phase 3 to phase 4 is a super test. Because we don't know in heart failure patients what that rate of progression is, right? And those are shorter studies because with literature, we know how long it takes to progress to each phase. So let's say your test was applicable to heart failure patients, and you could actually tell which patients are going to progress to the next phase. Huge value right up there, right? You will not get comments like mine all the time. Does that make sense?
Yeah. So my
Yeah.
point was, suppose in your own comments, if you say phase say 0, 1, 2, 3, 4, the study could start at 2 and go to 4, or 1 and go to 3, rather than 0 to this, because the duration can be shortened.
Sure, absolutely.
Right?
Yeah.
So the study would look something like that, right? Where you scan a large population, you identify those who are at early stages, right? And then you are tracking them over a limited period of time. You follow Dr. Parikumar and
Yeah.
huh? Rather, so that is also okay as long as you're able to establish that that's a good indicator, right?
But also, Tanya, I'd like to mention here one more point.
Mhm.
Like, you cannot single out only endothelial dysfunction and
Absolutely.
predict the whole patient's outcome. So
Eh, eh,
we also, like BrainC, we also are working at developing an index, incorporating various indices into it. So we cannot purely go by just one particular parameter. So our
Yeah.
parameter
No,
does play a very significant.
absolutely. But if you remember, Shobha, what did I bring up last time? Which is why I like always keeping the product in mind, right? Absolutely
Yeah.
right. So what did we discuss? Like this is just one of the metrics that you're measuring that you want to
Yes.
add on to, right?
Yes.
What is measuring? So this is why I keep talking about what are the metrics you're going to use. So let's go back to BrainC for a minute. What they did is they combined MRI because they know that's being used with cognitive scores. So now you know why your population is so important, because you need to
Yes.
look at all these other factors that are already there. So I'm completely with you. At the end
Yeah.
of the day, what you have to show, which by the way is a huge challenge, you have to show that the addition of endothelial dysfunction to all these four, and I think you'll have a beautiful slide on it actually,
Yeah.
Yeah.
is
You
going
remember
to make decision and treatment better. Do you
Yes.
you have that slide? So I don't see how we are closer to the goal in selecting the population based on all that, though.
Yes. I get you, Tanya. But as I told you, we'll take a pure population and then keep working towards the progression. And then we will bring in those risk factors, because we're going to have a control population with asymptomatic right now, but history of family history, or, with the predisposition to developing the disease. So with them, we can just put together and see how the score will take them. So, like, for instance, we've just brought up of the score.
Yeah, but just 1 minute. Some of these other indicators were, I think, little late stage. Am I not right?
No, not necessarily. Because this we are fixing the upper limit of the age to 50 only to counteract these strong influences because of these diseases. So when it comes to the younger age group, I think we'll stand a better standing. Though we are including these diabetes, hypertension, it is not necessarily an end, right, because they are very young. They've got these diseases. So it will help us to kind of solidify on the scoring system. And if we are able to give a score, we cannot give absolute values to any patient. So if we are able to give a score, I think that will give a better guidance to the doctors to treat the patients accordingly. And our parameter is going to be very influential in predicting that score. We can work on this scoring system this is subject to any kind of modifications. We can also verify, and we can make it as best as possible. And I think this will finally help the patient and the doctor ultimately. So we have to
Yeah.
design our study around this.
Yeah, but in this, some of these are very large, like complex ones, diabetes, hypertension, all that, right? So if you're leaving that out, the remaining are all related to your, am I right? It's related to your endothelial. The first 4 columns that you have, 1, 2, 3, 4, 5,
Yes. First 4
5,
columns
are
are
all,
about
all
endothelium.
from the capillary ones only.
No,
Yeah.
we need to include these also, Dr. Premnath, because otherwise, just by
Yeah,
using
but
only
you
our
are, but we are now selecting a population which doesn't have diabetes, hypertension, all of that, right?
yeah,
Yeah.
but
So
only
Yeah.
history, family history. So in the due course of time, we are going to see how many of them are going to develop diabetes or hypertension or any of
no,
these
no, no,
diseases.
no, don't go down that at all. I'm saying that's not relevant at all. Diabetes, hypertension, not relevant. Just heart. If you're focusing on heart, just focus on heart, right? Because the idea is to do a clean study which establishes the relationship very clearly.
Uh,
Yes.
yeah, but if you see, I don't know how to explain. See, but if you see, there's not a patient with a pure cardiovascular disease. A patient with say myocardial infarction will not have a pure myocardial infarction as such. He is most likely to have diabetes, most likely to have hypertension or anything else,
See, suppose
or
you have,
at least a family history, something like
no,
that.
no, listen,
So we
what
cannot
point
have a
is,
pure. Sorry.
listen, suppose you have 100 patients, okay? Maybe 90 of them fall under the category you are mentioning. But there'll be 10 who don't have those complications, and they'll be
Yes.
the population which will be a good population to clearly study,
Okay.
Yes.
right?
Yes.
Yeah.
Otherwise you'll get nothing out of it, because then you don't know it was due to your endothelial dysfunction or due to some other complication.
No,
Okay.
we are only some other complication. Not that's not what I'm talking about. We are only saying the endothelial dysfunction is the first thing that happens in all these patients. So we are able to catch them at that point. Whatever can be done to prevent progression of the disease from endothelial dysfunction to any of the XYZ disease.
Yeah. So anyway, see that study can be designed, but the point is, right now, so far
Our
have
test
done.
will be the
Yeah.
parameter.
Yeah. So far, the patients that you have looked at, all the samples, do you have a group which is showing dysfunction but has no other complications?
Yes, that is
Yeah.
what we are anticipating.
So you don't
That is
have
what we
yet
are
anything?
anticipating right now because this comes on earlier in the clinical progression. This endothelial dysfunction comes on much earlier than the other diseases that quite quickly follow. So there's definitely going to be a subset of population without with endothelial dysfunction alone and without any of the diseases. That is what we are trying to prove. But in our earlier studies, we have also found that around 10% of patients with with diabetes and hypertension, with 10% of patients with diabetes and hypertension did not have endothelial dysfunction. So there's another area that we really need to look at. I don't know if I'm complicating the things, but this is what we found out from a small subset of population that we studied. So that 10% of population, I'm intrigued by that because they did not they had diabetes, hypertension, obesity and all that, but their endothelium was well maintained. It was very good. So I'm trying to imagine a situation. I'm trying to see if these are the patients who do very well clinically despite having diabetes, hypertension. I'm also concerned about the 20% patients we saw who had 20% of our patients whom we studied had no diabetes, hypertension, obesity, nothing. They had nothing, but they had endothelial dysfunction. So I could not do a follow-up study on those patients because they were from the camp settings and we could not do a follow-up study. I would have loved to do a follow-up study on those patients to see how they have progressed. So this kind of answers our clinical scenario right now that we are facing, which says there are some patients who are absolutely normal. They go in for a sudden myocardial infarction or they go in for a sudden cryptogenic stroke, all those. But whereas there are some patients who are diabetics for years and years, they still have not developed any kind of end organ damage like retinopathy or even nephropathy. Even retinopathy they have not developed in spite of being diabetic for years. So this kind of changes our whole clinical picture of what we are seeing, and this kind of will answer the very many questions that are running in the clinician's mind as to why this patient, without any of the comorbidities, without any risk factors, suddenly had an MI, whereas this particular patient with so many years of all these comorbidities has not developed any end organ damage. So to lead us into a clinical decision, I think our parameter will really play a very important role. So these patients which we are seeing are normal, but ending up with a myocardial infarction or stroke, they would have actually been having an endothelial dysfunction which was not hitherto identified in that patient. I don't know, Tanya and Dr. Premnath, like you can tell me, because I am more towards this clinical side, and therefore I
I can tell you this is not even interestingly enough disconnect, but ironically everything you said actually supports why this clinical study may be difficult, but you're coming at it from a point, and rightfully so. Trust me, I am currently working with a Harvard entrepreneur who has a brilliant discovery. It will change everything we know. Let me not go into the details. And it's the same problem because he's not going to get adopted. And no amount of telling him, because he's so driven by his passion. And then finally, we had to get industry leaders. I had to invite them to say, how will you get? So there are some projects that advance our thinking of pathogenesis of the disease, that push the boundaries of knowledge, right? And more power to them. I think what we are trying to do, and maybe not the right thing to do, if you needed to build a company, there are tools that are research tools only, right? They remain within research labs. They don't become really commercial tests. They are very good tests. And I think one thing that has to be discussed, you all and the team, is what is the end goal? Because on the path and with your observations, you all will do just fine. You all will keep looking at these studies. You all will get all these patterns. But that's completely different from building a commercially diagnostic tool.
Yeah. We need your help in this, Tanya. Like, I mean, that is where we need you to help us. And whatever you tell us, we'll work around it. I just wanted to pour out whatever.
I don't want to kill your clinical enthusiasm. I have the same challenge with my wonderful entrepreneur. I think he's only now learning that this is very difficult. He has a very good place in the law. There's not a single person who will listen to him and not say this guy is top notch, the technology. It's very similar problem, but. So I'm trying to understand all these studies you're doing, this very great insight that you've had about this segment of population. Now think about it, okay? I am going to act like I'm a non-science person, and I'm just going to put a business hat on. So let's say all these different populations, these patterns you're studying now were enrolled in your clinical trial. Can you imagine what that readout would have been like? Because you're looking for statistical significance at the end of the trial. You need that. Let's think you're fundraising. You just took all the money from investors and you said, in 1.5 years, I'm going to prove to you that this is a new metric. You will not be able to do it, Dr. Shobna, but not because you're not right, but because you're not asking very good questions in a complicated system.
Okay. So how do we get around this now? Because I don't want it to just be a clinical thing and end there. It has to commercialize. It has to commercialize not just from the monetary point of view, but from the patient utility point of view, from the clinician's utility point of view, and for the patient's benefit. I think let's answer so many of the unanswered questions that clinical.
Let us ask the simple question: if there's a test that somebody is paying for, what is the key learning they will get which is actionable. Okay.
Yeah.
So now, suppose there is a person, if you say that, that this is a test where somebody can come to know early that they have an endothelial dysfunction issue, right? And therefore, doctors can take some action or they can do some preventive action. Fair enough. But the question is, who will be those people who will want to get this test done? Because if you're perfectly fine, why would you go and get a test done? Right? So, from the commercial point of view, one needs to
Yeah.
ask the question, what is the test and what is it going to teach whom? Right? Don't mix it with your clinical learnings and your explorations and research explorations. That is not relevant here. Okay.
Okay.
The simple thing is, if it's a doctor who's going to advise a patient go and get this done, why would they get it done? And I mean, and what, because they'll have 10 other tests they could get done, right? So why this one? And what would be the reason they would get it done? And what would they learn from it? And what would action would they take from it? Right?
Sorry,
This is
but
a simple question to ask. And all this has to be very, very credible and not something which is just hand waving, saying that, because we did all these studies, we think it's relevant. That won't work. Okay.
but Prem, I'm also going to ask. So let's not think about endothelial cell. Let's stop talking. Who is the population we're going to apply this to? I remember in one of the meetings, Dr. Pari had said, I want to go after, and if I'm misremembering, please correct me. It was the guy who was on the treadmill, right? He's completely healthy. He has
Yeah.
no history running on the treadmill. See, that's the kind of thinking we need. Forget that we have got to identify who. So when we keep saying, the patient, because the patient is not going to care. I mean, come on, the layperson is not going to care what their endothelial cell count is unless you present it in terms of the disease. So what are the patients we are looking at? Are we looking at myocardial infarct patients? Are we?
Yeah. Let me come up with an example, Tanya.
Okay.
For example, a person with 300, 400 sugar levels. There are many people walking around with 300, 400 sugar levels. And if that person has normal vascular endothelium, that person could be branded as a non-risky diabetic. Whereas on the other side, person with just 100 sugar levels are well under control. If his endothelium is unhealthy, that person needs active treatment. That person could be branded as a risky diabetic. So this kind of transition can happen in handling the patients.
See, that is not what she's asking, Pa. Tanya, that is one thing. I was also thinking at the subset of patients that we can interestingly look at would be patients, would be not patients, would be persons enrolling in a gym or something like that. Okay, very young people only usually enroll in gym. So we can use that set of people to say, like, there are lots of people who die very young after a gym workout and stuff like that, not necessarily because of any risk factor that they have had, but it is maybe they had endothelial dysfunction. So interestingly, we can look at the endothelial study of patients who are enrolling in gym, or even I was telling Dr. Premnath the other day about enrolling patients who are coming for insurance, for insurance coverage when they come.
That may be not a bad idea at all. Actually, you'll have to work with more, because in a way, if your test really works out, you realize they'll be denied insurance, right? Or they'll have higher premium. So here you will need to get the support. So we will have to discuss the ethics of doing this and whether that's what you really want. But that is a great example of how there is immediate value to it. But hold your thought, Shobha. I also don't want to dismiss what Dr. Pari said. Only I was smiling because you told me cardiovascular stroke, but your example to me was totally about diabetes. So you have got to decide really where you want to put this tool to good use.
Okay. So, I mean, you think that will be a good idea to enroll such patients into our thing? But will they agree? That is a big question. But if we can give this as a proposition to the insurance people, they might be very, it may interest them. And we'll also have a pure set of population.
Well, I'm sure the insurance company, so we are talking about all
or
this.
even or even patients coming in for driving license. People coming in for driving license at such a young age, so they need to have their eyes tested
No,
or something.
no, that's
That won't
too,
work?
no, I think, yeah, I wouldn't do that. The insurance thing is not a bad, the only thing to consider there is, so in terms of a business case, a business model, I think it's a great example. When I said you do need to think about the ethics of the whole thing, is because you're gonna have to have the patients. The insurance companies could, end up denying insurance, right? Unless you, yeah. So this, but at least in the right track of thinking about a business case, I guess.
Yeah.
See, if are there situations? Hello, can you hear me?
Yeah,
Yes,
yeah.
Yeah, no. Are there situations where, say, for example, people who are going into initiating strenuous exercises or running marathons or wanting to do some of these like climbing episodes and so on, those kind of things, are is this a test which can at least indicate if there is a risk to them, right? They look healthy otherwise, but is this
Yeah.
something which should say that, because most of your stories around sudden death cases, right?
Yeah.
Cardiac arrest. I
Yeah.
presume those will be people who are, otherwise look thinking that they are fit, but this comes up. So is this, even though it might be a narrow population, is this a population which would want to get this test done before doing anything very strenuous?
Yeah. Yes, maybe. Yeah, that sounds.
Dr. Premnath, we would like to introduce Dr. Jose Jasper, is part of our team, is a neurosurgeon in Kaveri.
Mhm.
Yeah,
Yeah, good morning. Yeah.
good morning.
Good morning. Good morning.
Sorry,
Sorry for joining in late.
yeah. No, Tanya, what is your view on that?
So Prem, my only concern with that one is one or two. Why is this annoying screen showing me like on both things?
Yeah,
Can we
Because
take
I think,
Dr. Pari, can you please stop sharing your screen?
yeah.
Yeah,
Yeah.
thank
Yeah.
you.
I'm sorry. We're sorry.
So my only challenge with that use case, Prem, is then marathon runners do their health tests. They don't have to use particular labs, right? You can go and get this done anyway, and it's not as rigorous. The value coming out of it is not as rigorous as something else where, and then it goes more into the realm of like wellness, right? Which you don't want to do when you're starting a product like this. I don't think it's a great idea to go into fitness and wellness.
Mhm. Okay. What if you consider this as a niche application for which you establish some validity and then move into other things? Because at least that population will be relatively pure, right? In the sense it will be with less complications, simpler system to look at.
Right. So I want to reemphasize what I meant when I said pure. Like it shouldn't be a combination of diseases in that environment, right? So if you're picking early Alzheimer's disease patients or even pre-diabetic patients, those are pure in itself as they don't have other confounding factors. So it's
Yeah.
okay to pick a complicated pathogenesis. Just think it shouldn't be something that is
See, the other observation, Tanya, was that all the other tests that are used today are fairly late stage. Okay, in at least cardiac health related ones. They show up when things are really not looking good, right? So I don't know if using a combination of this is because people are anyway going to go and get all the rest of the tests done when they have reached that stage.
But when you say use early, I'm going to ask the same question for we early for what kind of patients? Stroke patients, cardiac patients, heart failure patients? What is the pool that you're analyzing?
I told you, no, the pool that
The
we are.
50, not the demographics, Shobna, not the demographics, symptomatic, symptomatic. It's not that. It's
Okay.
I'm talking more about the pathogenesis of that population. And I'm thinking about it very narrowly. I'm only thinking about it in terms of your proof of concept study. You don't have a proof of concept study, you can't build a commercial tool.
Yeah. So for example, if you take a patient population where you would normally get an ECG done or an echo done and so on and so forth to see, or an angiogram done, so on and so forth, that's already pretty late stage probably, right? That's what, so when we were listing those, we felt that those are all late stage, and then you have this one, which is an early stage. And, those two don't seem to, I mean, I didn't think they overlapped as much, except in those cases which Shobna mentioned, where the rest of it doesn't catch it. But this indicator catches it in terms of endothelial
But
dysfunction.
catch what? So catch what? An early stage of what?
Of what they are calling as endothelial dysfunction, leading
No,
up
but
to
that is.
cardiac event.
Oh wait, but that how would one? How, let's say you have an IRB. What are you going to enroll? You're not going to enroll early in endothelial cell dysfunction, right? Your IRB would have early stage of what? I mean, you can't use endothelial cell dysfunction as a metric to enroll patients, right?
You would say maybe we can say early stage of metabolic diseases.
So something like that. I don't know, but you see where I'm going. I don't know if you want to say metabolic diseases for the reason I told you, but exactly something like that. You can't say early in a metric. You have to say early in the pathogenesis of whatever disease, whatever you'll select.
Yeah, early stage of metabolic diseases is good enough.
But what
You
does
want
that mean, Shubha? What does early metabolic disease really mean?
That is what this endothelial dysfunction, we are terming it early stage of metabolic.
But you just changed the name. You didn't change the
Yeah, I
thinking
mean,
behind it.
what else can we do? The clinical situation remains like that. So, I mean, how do we word it differently?
Why don't we go to Dr. Pari's exam? So maybe let's humour everybody. I do have a hard stop at 9. I have a call. So
Okay.
let's go. Let's, guys, this is team. This is what you should do. You'll really need to sit down. You'll need to put neurology in this thing. I thought the whole call with Dr. Jasper was regarding that. You need to put metabolic disease, cardiovascular disease, and stroke in 3 different buckets, and then do the pros and cons. So let's just go for a minute to what Dr. Pari said. When you were talking about the sugar levels in non-risky diabetic patients and the risky diabetic, let's hypothetically assume you're going after diabetes.
Okay.
Now tell me, what is the value proposition you're offering to those patients?
Okay. This exactly. If I have a diabetic in my hand right now, or even a pre-diabetic, okay, if I have an endothelial test done on them, I might be able to predict the seriousness of the course that they are going to take.
Okay, hold that thought. So I'm going to challenge you. Here's what so what do we use? Don't say this and that, Shobna. Just pick one. You have to show progression. So by the way, this is all for discussion. Okay, so let's say you are saying, it's not exactly what you said, but that you are going to be able to predict the conversion of pre-diabetic to diabetic. I'm making this up, so work with me, please. Today, what is used? Hemoglobin 1AC, right? We know that between us, beyond a certain. So then what you're offering is, I'm going to take this, I'm going to design my test in pre-diabetic patients, and I'm going to show that I'm better than hemoglobin 1AC. If you're able to do that, you have a use case there, right?
Okay.
But can you do that? I mean, I don't know that. I don't know that this is going to work. So you all
Technically,
have to think
yes.
about it.
Technically, yes. But I can also prove otherwise, in the sense, pre-diabetic with a good, yes, yes, technically, I will be able to say if this person will progress to be a diabetic, and a diabetic, whether that person will progress to be a bad diabetic. Technically, yes, I can do that with this
What does
test.
bad diabetic mean?
A pre-diabetic is someone whose HbA1c is less
Fine,
than,
what's
is
no,
little over
when
5.6 to
Bad,
6.
he's asking bad diabetic.
no,
At
the
the same
terminal
time,
condition.
I will also be able to tell whether a bad diabetic, according to just his blood sugar levels and his HbA1c, will develop end stage complications or not. I can also
You know
do that.
what? You know what? If you're guys, but you'll really need to spend a lot of time on this. I'm not kidding. Or all of your homework, all your reading has to be studying these populations. This is not easy. So let's take the other one. Shobha, be careful. The ones you're going up against are tests that are very inexpensive in the market, because
Yeah.
you're going to go up against hemoglobin 1AC, fasting glucose, postprandial glucose, which are very 100 rupees tests. So
Yes.
that's why when I keep saying you have to look at the business angle, you can't come up with a 3,000 rupees test when people can figure it out with $100, right? So I'm just throwing challenges at you. But let's go to
Yes.
something that you said, which is, please define the patient populations. I am begging you all to do this. But now, if you look at the diabetic patient population and you're making a claim, I can predict those that are going into end-stage renal disease, for example, because of this great use case. And then to Dr. Prem's earlier point, you have a patient population that would have progressed pretty rapidly. And then you can show how, because of your intervention, you can manage them better. But you need to think through things like this, right? Think through something like this.
Okay.
Okay.
And
But I
actually,
thought,
it's not a bad idea for you all to revisit the neurology thing as well.
yes.
Yeah.
Jos, your
Yes.
inputs, Jos.
Is there any
La-
use case? Is there any
Mm,
use case in neurology where you
mm.
see this biomarker from the conjunctival endothelial cells indicating something useful which is of diagnostic value?
Yeah, I think it is actually, I've been listening to the last, say, 15, 20 minutes. How do I put it? Endotheliology, the study of endothelial dysfunction, is the way forward. I don't have any doubts about it. But the long term, because like Tanya always keeps on saying, we have to prove a definite, link. And that is where we are struggling.
Exactly.
We can do something like we had thought of this a long time ago, because we do get lots of patients with young stroke. Now, stroke is actually a endothelial dysfunction disease most of the time. So, young stroke, like patients with 30, 40 coming with acute stroke and all that, lots of times they do undergo surgery also. In fact, very way for, long past time, we were thinking of whether we can do a vascular endothelium study directly from the brain. Because anyway, when you're operating, it is easy to get a 2 centimeter, a small vascular, like a small arterial sample. So we were wondering whether we can do that. But again, where we got stuck is in those patients, how do we get a consent to get a conjunctival biopsy? That is where we got stuck. If we can do both together, because India is now one of the capital of metabolic diseases, number of stroke is very high here. In our center itself, we operate at least 5 to 6 patients who are younger than 30, 40 for acute strokes, hyperacute strokes. So I don't really know how to answer that question. In the sense, we all know there is some endothelial dysfunction, but if we can prove a link, then it would be the way forward. That is what I think.
Okay. I think we are coming to the close of the hour for for Tanya. So just wanted to check up. So one is you mentioned, Tanya, that we should look at the specific populations, but I think um, we still haven't. Wouldn't the population also depend upon what value we are bringing to them, right? We'll have to choose that accordingly, right? So it'll be aligned with that. So probably we'll have to look at the value proposition along with it in terms of what value we are bringing. So we'll dig a little deeper into that.
Yeah.
But the
And Prem,
neurology one, so yeah, we'll also try and figure out more. Yeah.
I would take one step back and actually look at all the different ones that was mentioned today, right? So look at cardiology, look at stroke, look at diabetes, look at heart failure. And then ideally, when you do this kind of brainstorming session, so for example, the challenge that Jasper just brought out, right? Like if you do this from that's why I said from an ethics and IRB here, it won't fly. Not somebody who's going for brain surgery. It would be very difficult to justify, getting so that would be the challenge. And that's how you start like filtering out.
Okay. So I think we will work on this a little bit and come back by the next meeting, right?
Exactly.
It's already 9 for you, so you can sign off probably.
I'm going to go.
Okay.
Okay.
Thanks,
bye.
Tanya.
Bye.
See you.
Bye.
Can others stay for a minute? Yeah.
Yes.
Yeah. So I think, see, some of this finding out the right use cases and value propositions is extremely critical. Rest of the study and all can be designed once you've got that right. Okay. So it's important we identify what is the specific use case for the diagnostic. Okay. Don't confuse it with clinical insights. And see, you can always write a paper saying that this is correlated, that's correlated, all that stuff, but that doesn't cut it as far as business is concerned. Okay.
Yes.
It has to be a very clear indicator of something which a clinician can act on. Right.
Yeah.
So we need to identify that use case. So I would dig deeper into, specific cases and see. And if that use case is clear, you will know who the customer is, you will know what the product is, and you will also probably be able to design a study to establish that use case. But I think her point is don't complicate it too much.
Yeah, the whole problem is the use case is so diversified, Dr. Premnath. Like it's
listen. Let me put it this way. We have many companies who will have products which are applicable in many different ways. Okay. But we will not chase all of them at once, right?
Yes.
We will choose only one where we can prove that it works. Okay. And where we can get regulatory approvals, where investors will be convinced that it works and then go ahead with it. Later, the rest of them can fall into place.
Okay.
Right.
Okay.
So it doesn't diminish your work in any way. It is just being focused because see, at the end of the day, all this costs a lot of money, right? And you need money from investors. Now, those investors are basically looking for one simple story which says that this is a clear use case where money can be made. That's it. Okay.
Okay.
That's all that they will want to know. Okay.
Okay.
Now, so what we are doing is we are and what Tanya is saying that the burden of evidence is with us, and if we just present a lot of data, that doesn't mean that presents the evidence. Okay, you can do a lot of clinical studies, but that doesn't establish the clear cause relationship which you need to do a diagnostic. Okay.
Yes, sir.
So I think as an action point, you have few use cases. One is neurology. One may be, in cardiology, you're saying that this will be the problem that will kick in.
Yes.
We need to sort of identify a narrower problem where you can actually clearly establish that it works. So can you just look at that a little bit, please?
Okay.
Yes, sir. We'll
So
work.
In neurology, do we have any cases where we can clearly say point to this? I mean, would we say that this is an early indicator of something. Is that possible?
Yeah, that's what
Yes,
Joe said, no?
yes, sir.
It is.
Yes, definitely we have scientific evidence. So maybe we can work with young stroke patients and find out how their endothelium is, and
No,
maybe
it's an early indicator of what? Of stroke, you think? That's what you're saying?
yes,
Yeah.
yes, yes,
They're predisposed to
yes,
getting an early
yes,
stroke.
yes.
Yeah. And is there a good paper on this, which is a credible paper, which has done this measurements?
Yes, sir, we have lot of papers.
No one has done the endothelial
Endothelial study,
dysfunction measurement. Nobody has done. No.
We have evidence that endothelial disease causes stroke and
Ah.
MI. We have evidence for that.
Hmm.
But no one has studied the endothelial dysfunction so far.
Like, is there epidemiological studies saying that this fraction of stroke is due to endothelial dysfunction?
Actually,
Joe's-
most of the
Strokes
diseases
are
are due to endothelial dysfunction only, sir.
most strokes are due to endothelial,
Endothelial
especially the stroke in the young are due to endothelial dysfunction. Joe's?
Yes, yes. Thing is, hello.
Yeah.
Yeah.
I am losing my signal. I'm actually in the basement parking. But but endothelial dysfunction is a major cause of stroke, and it
Yes.
is proven. There are lots of articles.
Lot of articles. Yes.
Yeah. And is there a clear case where this is the primary cause rather than any other complications kicking in?
Yes, sir. We have definite
Joe's
evidence.
will answer.
Yeah.
Joe's?
Yeah, we probably lost him because he might be.
Yeah.
Lots of papers regarding that. Yes.
Okay.
Can you hear me?
Yeah, we can.
Yeah.
Yeah. Is there a good study in Lancet or New England Journal of Medicine on this?
Yes, sir. We'll pull out.
Yeah. I would want to see something which is a well-powered study without complications, without too many confounding factors, which establishes, a very clear relationship. Has anybody done, say, for example, taken patients and done some, biopsy or studied the endothelium post event?
That's what pathologists have seen, only pathological samples. Physiological samples they have not seen. That is what we have seen with pathologists. Roughly about 20 pathologists we have presented with. They all have seen only pathological samples. Physiological samples they have not seen.
Till now, sir, there was no way by which somebody can look at somebody's blood vessel or the endothelium.
Yeah, I got it. I'm just trying to think of, it's a no doubt that it's a good sample to have, and there will be new insights that will come out. We just need one insight that really is very authoritative. Okay. Let's work on that. Shuchi and Pragna, can you please see if you can also do a little bit of background work? I hope you understood what the request from Tanya is, right?
Yes, sir.
Have you noted down what is the key ask? One
Yes.
is we need to identify basically a sample population, say what that sample population will be able to identify in them, and what would be a proof of concept study establishing the that marker, right?
Yeah.
And the other is the BRAIN-C. Pull out the BRAIN-C and also request the for the FDA document for which she mentioned. Okay.
Yeah.
For an early indicator. So Pragna, you can write to Tanya and get that. Okay.
Yes. Fine, sir.
Okay, fine. Okay, we'll stop here. Thank you.
Yeah. Thank you.
Thank you.
Thank you, sir.
Thank you.
Yeah, thanks.